Thanks again for having you today. A short introduction for those who just joined. Professor Mark is a senior consultant. He was the head of the Department for Internal Medicine and Infectious Disease in a hospital in Cologne. And he's now presenting today on HIV and ICU care. We're really happy to have him. He was just having the pleasure of having him in Ethiopia for 4 weeks for ultrasound endoscopic workshops and also some infectious disease training. So he's very well into what we do here in Ethiopia and also into stairs. And yes, again, thanks to Mark. Really happy to have you today. And I'll hand over the word to you.
Oh, yes. Thank you very much, Pascal. And good afternoon, everybody. Thank you very much also for inviting me to giving this talk on HIV infection and intensive care medicine. Also, thanks to the STAIRS project and the Sepsis Foundation. So I hope I can contribute a little bit to this topic. And as Pascal already said, we right in the last weeks we had quite an amount of cooperation, which was very nice. So perhaps you should give me a call, a short feedback whether it is possible you can see my slides and you can see it moving on.
Yes,
Is
thank
that
you, Mark.
working?
Yes, we see
Pardon?
the slides and it's moving.
Very nice. So just keep on. These are my conflicts, so I don't have any financial interests on this in this area. Still, I have some honoraries for giving talks in other topics, also in HIV medicine. Okay, we just let's go just briefly into some basic things before we go more deeply into ICU. As you all everybody knows that we have quite a high, still a high number of HIV infected patients worldwide. As you can see, these are the most recent numbers of the WHO, with more than 40 million patients living with HIV, infected with the virus, and even more than 1 million are coming to this each year, with more than 500,000 people dying from HIV. That makes these numbers over the time, starting from 1990 to 2024. Although the numbers are quite high, we still see a constant decrease in new infections and a constant decrease in dying people due to widespread application of antiretroviral therapy, even and especially in the most affected countries. But also you can notice that there is a gap between the people that are dying from the disease and people that are new acquiring HIV infection. This leads to a constant increase of patients, of people living with HIV and AIDS, so that we will have in the next years and probably also the next decades still an increasing amount of people that we have to care for. And it's not the topic of my talk, but everybody discussed that very intensely in the last months as the funding from especially from North America and Europe is decreasing in these days and in the coming years. The situation will not improve too much. On the other hand, it will become much more difficult to keep the services up. Okay, as we just had the cooperation with working together in Ethiopia, I have some slides integrated in my talk. And as you everybody knows that Sub-Saharan Africa is the together with the Far East and to a lesser extent South America. So if we have a short glimpse on the numbers of Germany, this may just be an example for the situation which is to be seen worldwide. Our patients tend to get older and older. This it's a German slide, but these you can see the years of the until the beginning of the 2020s, and in the upper part it's the number of patients in Germany getting older and older, which the darkest areas here is above 70 and still above 80, which is also increasing, but to a highest extent, the increase is seen in patients from perhaps something like 45 to something like 70. These patients are now coming of age, and due to this, we find all the problems that we have in an elderly population. I will show you in 1 minute a slide on that. But also, besides of that, we still have, especially in the countries of Europe and North America, quite a fixed number of late presenters. That means patients that are diagnosed late. For example, they have a low CD4 cell counts, immunosuppression, or possibly they have developed AIDS already. These are the late presenters, and we were unable in our areas to get a good hand on this to make this things better. And if you look at these surveillance data from Great Britain, there's a comparison of the mortality of these patients. That means diagnosed late are these patients as we call them late presenters, diagnosed promptly. These are the patients that receive the HIV diagnosis with still having a good immune function and not having developed AIDS. And the mortality is differing by a factor of about 10. Yeah, you look at about 30 of 10,000 patients compared to 290. And if you look at another classification, it's just the same. It's 30 to 300. It's mortality 10 times higher than in patients that do not develop immune suppression. And this is what I just was discussing. The mortality changes. These are many cohorts of different countries worldwide, and many patients with HIV have been followed up with this big study, 15 years of follow-up. And on the left side, you can see the mortality reasons of the patients in the time being starting from 1996 to the last period of 2016 to 2020. And on the right side, you can see the same thing with a focus on the elderly patients. And what we find in here is that the green bars are decreasing significantly. This is AIDS. So mortality of AIDS is only a small amount compared to former times. What is increasing is the red area, which is cardiovascular diseases. We have to deal more and more with cardiovascular diseases, and the biggest increase has to be seen in non-AIDS defining cancer diseases, different types of cancer that are increasing so much And the last two bars, are bars with diseases, different kind of illnesses that are common for elderly patients. So our elderly patients will increase to be dealt with on the intensive care unit. And now I'd like to show you some data on ICU and HIV, starting with a very old study, but this was published quite well in the New England Journal of Medicine. And the people of the former times found out that most of the people, the patients that had to be dealt with, were suffering from respiratory diseases. So they had to go to ICU because of respiratory failure. And other things like sepsis, which is important for us now, are much smaller, the numbers, but still quite intense in comparison to neurological conditions and cardiovascular diseases. And then we have some different things that are of minor importance. And if we want to look at more modern data, we have to bear in mind what kind of manifestations of HIV disease we will have to face in different immune strata. So in all patients, and especially in Sub-Saharan Africa, tuberculosis is a big topic. Without any respect to immune function. And there's a number of other conditions that mostly are infections like herpes or bacterial pneumonia, or malignant diseases like lymphoma or Kaposi sarcoma. And if you look at these subsets of people that already developed immunosuppression, then we have some corridor-like areas where some diseases are quite common, although it's not an absolute differentiation. So below 250 C4 cells, we have the pneumocystis jirovecii pneumonia or candida infections, or I just will later on show some examples of these. And if it goes still lower with further progressed immunosuppression, we get something like cerebral toxoplasmosis or severe tuberculosis. We also have some neurological conditions, and these patients that have the lowest C4 cell count have still there's some other diseases are even more common, like CMV, like cytomegalovirus infections or cryptococcal infections. And let's have a look at more modern publications, although there are not many on these topics. This, I think, is quite helpful if we are doctors on the intensive care unit and people have to be admitted to ICU. What kind of general conditions have to be dealt with? So if you have acute respiratory failure or neurological disorders, we just saw that a second ago, that these are the most important things. Then we can have a look at the patients, whether they have far progressed immunosuppression or not. And besides this, there's still also acute HIV infection. That means the freshly determined HIV infection right a couple of weeks after the transmission of the virus. So there is encephalitis, for example, which is not very often, but it may develop. So, and now this is here, the CD4 cell count very low. This is what we just discussed. we have different pulmonary diseases that we have to deal with. We find this again, perhaps some more like aspergillosis or histoplasma disease, which is another fungus. Also, on the right side, in the neurological area, we have toxoplasmosis, tuberculosis, also cryptococcus infection. And for these patients that just recently started ART, the antiretroviral treatment, there may be an IRIS, which is immune reconstitution inflammatory syndrome, with different types of very inflammatory diseases. There may be some unspecific inflammatory reactions, or on the other hand, some exacerbations of pre-existing infections that become much more worse with IRIS. So, and in all patients, things like meningitis or pneumonia may be a topic, and in our elderly patients with still established immune function, all the other things that are common on the ICU may be the reason. So this makes HIV on ICU quite difficult, because we will have to expect all the let's say normal diseases that lead to ICU treatment, and on top of this, all the special things of immunosuppressions, and on top of this, all the special things like IRIS, which are only common in HIV. So this makes it very challenging to treat people that suffer from HIV and acute disease. Okay, I do not read all this down there, because you will later on have the possibility to look at the slides and work that up again. But in my impression, this is quite helpful. So, how about outcome? Still, the mortality of patients with HIV is quite high on the ICU. I just have a combination of many studies. There are some more, but these are some important studies with results that have a big spread of the numbers. Oh, somebody should mute himself. Yes. Okay, Pascal, perhaps you
Yes,
can mute
I'm muting.
the colleague. Okay.
Yes.
So, and if you look at that, mortality is between 16 and 58% in a number of studies, in comparison to HIV negatives, which is much more lower. So this is still holds true in our times nowadays, which gives us the need to become better and to address this problem more precisely in order to improve our outcome for the HIV positive patients. And if you look at the other mortality data, they also don't look so nice. For example, 90-day mortality, 81 compared to 59%. So there's still much to do to become better. Okay. And here, for example, it's a study from Ethiopia with a focus on sepsis. And it's looking at the data on the other way around. So all sepsis patients that had to be treated on ICU were divided by HIV status. And you can see easily that the HIV positives have a much higher mortality compared to HIV negative patients. So the other diseases are making the situation of HIV more complicated. and looking from a perspective from the diseases, HIV itself, it's a very important risk factor. So let's look at the most recent studies. For example, one big study from France, or some other compilation of studies. The prognosis factors to get out in the good conditions out of the ICU is like age or comorbidities, especially malignant diseases, as a negative factor. And uh, the most important diagnosis in these more modern studies were also, as we know already, respiratory failure, sepsis, and neurological disorders. So this, although I just in the beginning showed you the old data, it still holds true in our times today. So, and the mortality factors that if you look at that in more detail, we find the normal prognosis, or on the other hand, mortality factors that we know from intensive care medicine all the time. For example, the Apache score, the severity score of the diseases, or the use of special treatments like catecholamines, or the mechanical ventilation. These factors make a more disadvantageous situation for the patients. Also, again, sepsis with a high hazard ratio over 3 times, it's a really big issue for the HIV positives on ICU. Other things like CD4 or AIDS-defining diseases, also ART, are not so strong as mortality factors in more modern studies. Still, they are important, but the association nowadays is a little bit weaker. And again, I want to show you a meta-analysis from Sub-Saharan Africa, with looking at at the factors that have a adverse effect on the patients of the intensive care unit. Again, the strongest factors are age, and again, HIV. So we find all these factors in different types of perspective all the time again. So this is the reason why we have to address these so aggressively. Here again is a study from Ethiopia, which is a little bit special because it has not been shown for so many other countries. The cryptococcus infection is very important in HIV positive patients in 2 hospitals of Ethiopia with patients with CRAG, which is Cryptococcus antigen. The positive patients have an adverse outcome in comparison to other patients with, for example, sepsis, like bacteremia. Okay. And another important issue is ART still, although these data are quite old. If you start ART already on intensive care unit, with some exceptions, that may result in a more positive outcome for the patients. So if you want to have like a score or something like that to deal with the ART for the HIV infected patients, you first look at ART at admission. If the patient is already treated, try to keep it up as much as possible. And if the patients are not treated anymore, and then you have to consider some aspects, for example, this one, tuberculosis or cryptococcosis. In these cases, you will delay the start of ART because in these patients, the risk is very high. So if you start treatment of TB and HIV at the same time, you will have big problems after 1 to 4 weeks with severe iris. And I remember patients with acute liver failure and really big problems. Also, one patient died in this situation in former times when we didn't know that we should have a break for the ART initiation. But if you have another situation like severe acute HIV, start ART, or other things like PCP, that means pneumocystis jirovecii pneumonia, or other things, you can start very early. And if you have no HIV-associated diseases, this maybe started after discharge from ICU, because it's not so easy to apply ART. These are some examples that show that it's not trivial to apply the drugs, because especially in patients that have mechanical ventilation, there are no IV drugs available besides of AZT. That means that we have to apply the drugs through any enteric way, using catheters in the stomach or in the small bowel. But not all of the drugs are licensed for this, and not all of the drugs are possibly. You will have the application form as a solution or something like that. Some tablets may be diluted, so may be crushed and diluted, but some don't. May not be crushed because the bioavailability will dissolve, will go away with that. Sometimes you have to do doses modifications. These are only examples, as I said. In other groups, we have the toxicity issue, and we have many tablets that we may not dissolve. In protease inhibitors, there are some oral solutions, but some others may not be crushed. And we have all these big drug interactions. I will show a slide on that. For the more modern drugs like dolutegravir, may be applied via enteric tube, but not all of them may be applied. And this makes it quite complicated to do the treatment. On the other hand, we know that in some cases it's quite important to start it already on ICU, in the time on the ICU. And this is only one chart with a small amount of examples of interactions from the European guidelines. Here you can see all the different antiretrovirals, and there, for example, are some lipid-lowering drugs. Here there are some different drugs, for example, for airway treatment or an antacids and other. drugs. And this is just an example to give you an impression how complicated it is to look up all these drug interactions. And these are only dimeric tables. So we often give 5 or 10 different drugs where we are unable to know about the interactions. And I would recommend always to use the drug interaction checker from the Liverpool University, which is very, very helpful to consider the possibilities to combine other drugs with antiretroviral treatment. So these are the raw data, and in the second part, I just want to give some examples on the different aspects of different diseases that are common in our HIV patients on the ICU, starting with the most important and oldest manifestation, the pneumocystis jirovecii pneumonia, with a bilateral interstitial pneumonia. Here on the right side, you can see a nice CT scan of the lung. And in this projection, you can identify a very typical issue of PCP, which is an old abbreviation, but still in our country, it's still possible to use it because everybody knows it. You can see that the pneumonia is more centrally located with the edge, the borders of the lung somewhat not affected. There's skipped just on the contrary to, for example, to COVID-19, where we find the interstitial aspect of the pneumonia, especially in the edge or in the borders of the lung. And in our countries, we have many, many problems with allergy after the application of cotrimoxazole, which makes it quite challenging sometimes to deal with PCP, especially on patients that are mechanically ventilated. We have some PCP is a fungus. Candida infection is another very important issue. On the left side, you can see an endoscopic picture of the esophagus with Candida islets with typical whitish aspect. And on the right side, we have a far progressed immunosuppression in HIV positive patients. We are not able to identify the esophageal surface beneath the Candida infection. In these patients, they are not able to feed enterically. And other fungus are very important, like Cryptococcus, where in our areas it's mostly meningitis, but especially in Sub-Saharan Africa, it's, for example, the skin or the lung may be affected as well, in this case with the big cavern. And Aspergillus is a fungus which is quite common all over the world, with a typical fungus ball in the middle of a big cavern in the lung with a thick wall. This is a typical aspect of Aspergillus, which is quite difficult to treat because our drugs that are difficult to apply do not really penetrate in there. So it's necessary to treat them for a long time. Especially tuberculosis, it's a big issue, especially in Sub-Saharan Africa, it's much more common than, for example, in our area in Europe, but still we find it. But you know better than we do about this complication. In this case, for example, we have also a cavern in the lung, but the typical aspect of the tree in blood phenomenon of an early TBC in the lung, which is a typical sign. It's not specific, but it's very suggestive for TB. And in the patient on the right side, you have a dense infiltration of the complete lung on both sides, with thousands of points, like miliary aspect of the tuberculosis, which is a much more severe dissemination of the infection. And the most important and most severe manifestation is the sepsis of Landoucet. For especially for Africa, it was I would point out the ultrasound aspect, the ultrasound diagnosis of TB, which is a point of care ultrasound developed in Malawi. It's called FASH, focused assessment with sonography for HIV associated TB, focusing on pleural or pericardial effusions, ascites, lymph nodes, or liver spleen lesions that may hint to tuberculosis. In this case, I have an example of splenic lesions. You can see the spleen with a hypoechogenic area of quite a big size. There's another extra splenic lymph node, or perhaps an accessory spleen. There are some lymph nodes, another picture of the upper abdomen. There are big lymphatic nodes, which is in TB case, it's typical that in the center of the lymph node, it's liquid. This is pancreas, and this is the superior mesenteric vein. And here is an example of the tuberculosis, where after application of contrast using in ultrasound, so the contrast ultrasound gives us an impression of the blood perfusion of the area. So if you have a look at that, and if you are considering whether, for example, it may be malignant, you will find some perfusion, although maybe to a lesser extent in this area. But if you look at the contrast aspect, we find that there's absolutely no perfusion in this area, also in this. This is a strong argument for tuberculosis. And we have some other manifestations, for example, in this case of a patient of Nigeria with a big and significant fistula between the esophagus and the bronchi. This is contrast in the esophagus, and you can see that the trachea and the big bronchi show some margin with contrast agent that is the proof of the fistula, and you can identify the fistula in here from the in the trachea, and on the other side in the esophagus. And what we did, we applied a fully covered metal stent to treat this, and so this patient was able to recover from a disease that normally will not have the opportunity to be treated only with medicine. Okay, we have some other mycobacterial diseases like Mycobacterium avium, which is typically, as you can see in this picture up there, located in the small bowel, in the duodenum, where the villi of the duodenum are much thicker and whitish, with a whitish aspect that does not look so clean as the duodenal surface. And on the other hand, it's quite common that the mycobacteria affect the lung again. Down there we have some Mycobacterium kansasii producing some caverns quite similar to the TB. Again, here we saw some caverns from atypical mycobacteria. And cytomegalovirus is a big issue in far progressed immunosuppression, which may affect the whole body. For example, the retina in the eye, where we can see all these whitish inflammatory aspects of the retina with some bleedings, or in the stomach, you have an ulceration or another big ulceration in the esophagus, which is typical for a CMV, especially when the edges of the ulceration are quite deeply undermined. Here we have some examples of ulcerations in the mouth and the tongue tip, or on down there we have a diffuse inflammatory reaction of the large bowel due to CMV. And there's a little bit of data on this topic showing that reaction of a CMV is associated with adverse outcome, with a higher mortality, also in HIV negatives, but this holds true also for HIV positives. You can see the mortality almost 40% compared to 27 without CMV in the blood. But it was not yet shown that treatment in these patients makes any sense. But it was shown for HIV positives that patients with a number of copies of viral copies above 1,000 may have a better survival when they are treated. So they don't really die from infection, but in this area they die from cardiovascular or cerebrovascular disease. So the reduction of mortality by treatment of ganciclovir has been shown, as I said, and so we should have a look at that. For example, if the viral load in plasma is above 1,000 or 2,000, we should consider treatment in patients on ICU, although perhaps we don't see a clear manifestation of CMV, which is, in my opinion, quite important as a better treatment for our patients. So some other viral diseases like the PML, the progressive multifocal encephalopathy, which is due to JC virus reactivation. You can see it easily in all these whitish areas that are in the center of the brain, also here, not on the edges. So subcortical only, and this is so I showed you now almost something like 25% of the brain surface, which is easy to be understood that this is not compatible with survival. We don't have a real treatment for this. We have to treat antiretroviral so in order to wait until immune recovery starts, and then the body, the own immune system will get rid of this. And on the patient on the right side, these two pictures are from one patient. We did not reach that because it was so severe. We had an affection of the spinal cord. What you can see here, these are the whitish areas that are PML in the spinal cord. And in this projection, you can see all the bright whitish area that is affection of PML. So this is a quite very, very severe manifestation. Other brain affections are, for example, cerebral toxoplasmosis, which is a parasite, not a viral infection. And the typical aspect is an abscess of the brain or multiple abscesses. And when you apply contrast, you have the ring enhancement. And around the ring enhancement, you have the inflammatory reaction of the nervous system, which is quite typical for toxo. And another special aspect, which is very, very important for our patients on on ICU, is the fact that so many patients present with multiple manifestations. For example, this one, he had PCP and CMV in the lung, and again, the influenza, and developed multi-organ failure. You can see here the white lung. This is an early phase with the inflammations and the pneumonias, but there you have lung total lung, how do you call that, affection of this with the adverse outcome. And so we always have the duty to identify all of them, all of these manifestations. If you only identify two of these three and don't treat only two of the three, you won't have a good result for the patients. This makes it very challenging to do correct and good diagnostics in our patients on ICU. So I was just the total lung failure. That was the word that I was thinking about. Another example is the esophagus in this patient with viral infection, herpes, and fungal infection, Candida glabrata, which is also a co-infection. Or another example, these are only examples with also with herpes simplex, NCMV, and aspergillosis. So this makes it so challenging. And right in the beginning, I discussed the aspect of the malignant diseases. We all know that Kaposi sarcoma or something like non-Hodgkin lymphoma is quite much more common in HIV positives. But nowadays we can see that even more cancers are quite common in HIV patients and much more common than in the HIV negative population. For example, anal carcinoma, the Hodgkin disease, or other carcinomas, which are all much more common in HIV positive patients. So a malignant disease is not only Kaposi sarcoma, although this is the highest number. Here we have an example. In the white population, we often have the tip of the nose or the palatine, the hard palatine affected by Kaposi sarcoma. No. Also, this is an important issue on ICU, for example, not only with incidence of normal cancers, but also in atypical presentation. Because, for example, this one, the non-Hodgkin lymphoma, is very rare that this lymphoma is affecting the lung, like in the extent like this patient. But this is somehow normal for our HIV positive patients, that we have that more often and more uncommon. And another thing which holds true for example, for Europe or North America, and to a lesser extent, it's valid for other countries. We find many patients with intoxications because we have many drugs on the market. For example, this is GHB, some coma drug, which possibly many people know as a rape drug that you use in women because they are they fall into a coma-like status. But this is only also used as a sex drug in a lesser dosage. But dosage is not always very safe. So we have many intoxications with this, and also with the prodrug of GHB, which is very, very cheap. You can buy this for almost no money, big containers of this stuff that is normally used to scrub off graffitis from walls, but it's also the prodrug of GHB. So we had some intoxications with this in the last years, and one patient had to die from that. So let me summarize all that. HIV on ICU, we will this problem will be in our place as long as we treat patients in hospitals, because the HIV patients are coming into age, and we have more HIV positives worldwide. So more age-associated diseases which bring people to ICU. Most important syndromes are respiratory aspects, sepsis, and neurological disorders. Also, nowadays, malignant diseases, intoxications. We have this classical risk factors, so we have to apply good ICU treatment, diagnostic and treatments. And still, we have the worst prognosis in comparison to HIV negatives. So we have to do all our best to make good diagnosis and apply this difficult, complex therapy. So I would just encourage everybody to go into this topic and get as much as you can for our patients. And this is from our ICU. It's perhaps not the best time. It's the Christmas tree of our ICU of the last year. Okay, thank you very much for your attention, and I'll be happy to discuss with you some more aspects.
Yes, so first of all, thank you, Mark, also from my side. This was such a really wonderful presentation with a very well didactic structure and also really hands-on pictures and experience from your side. Thanks a
Yes,
lot, especially I think for Sub-Saharan side, the drug application, drug resistance, but also the interactions of the drugs. It's really important also with the iris. I don't know if
mm.
there's some other experience from, for example, Ethiopian or some other sub-Saharan African countries on that. Otherwise, I will open the session for any questions that might have occurred so far.
Okay. Yeah, you can use the chat also, or just speak. Everything is possible. Other opinions are welcome.
Okay, that seems that everyone is really happy.
Okay, then just leave it like that.
Okay, thank you. Tafese is writing. Excellent presentation.
So I apologize for my not always for the best English, but I just try to do my best.
Yes. No, I think
Yeah.
this is also more important than ever. We discussed it also because,
Mm.
in some parts, I mean, Ethiopia has at the moment still a relatively low HIV rate. But we always have to consider that those rates might rise, also from other countries and areas. So I think this is really important topic also on the ICU. I'm very much looking forward to the upcoming studies from Lena Kapavir. We also discussed there are some trials
Yes.
running in Eswatini, Lesotho, South Africa, right? At the moment, it's only allowed for usage twice a year with
Yes.
the injection, but there will be studies also which makes it more feasible with only once a year injection. So I think there's a lot of coming up, a lot of potential future options to actually prevent such events. But I think for a long time we will still see this on ICU. So thanks a lot, Mark.